It's a medical story of a male of 73 years old who present in 2012 a colon cancer with synchronous liver metastasis. Chemotherapy and left colectomy was done in 2012. In 2013, a right hepatectomy was done, and in 2014, a liver metastasis was treated by surgical segmentectomy. In March 2015, he presented an obstructive cholestasis over a hilar structure. IC at this moment was normal. CT scan, MRI, EUS do not show a visible mass or relapse. ERCP and percutaneous biliary drainage do not permit to pass the structure, and the 8.5 French external biliary drainage is left in place. An inflammatory stricture is suspected. So we decided to realize an hepaticogastrostomy with Dr. Bory and Dr. Devier in room 2.
So the idea to try to, one more time, to have access and to pass the structure, the suspected benign structure of this patient. So because we failed by the retrograde route or percutaneously, the idea is to try to puncture at the upper part of the left lobe through the stomach, the gastric wall, and to try one more time to pass the structure through this EOS-guided approach. And if we fail one more time to pass the structure, to place a fully covered metallic stent to have an access to the intrahepatic duct using cholangioscopy to find the way. So here we can see the left hepatic duct. I begin the EOS approach, and we found the dilated intrahepatic duct here. We focus, if you can have the X-ray picture, to find the to be another duct than the percutaneous drain. So,
and as you have seen on the previous endoscopy, percutaneous cholangioscopy, which was done by Erwan, its external catheter is probably in a branch of segment 4. And what he's looking to do is to make a puncture of segment 2 and 3,
2 and 3, yes,
in order to be in the axis of the straight part of the left hepatic duct.
So, we try to puncture this intrahepatic duct. So, here I use a 19-gauge needle. Because the dilation of the intrahepatic duct is not so big, I prefer to use 90-gauge, standard 90-gauge than access needle, because the puncture is a little more precise. So I will push gently the needle to enter into the intrahepatic duct, avoiding the surrounding vessel if I can. So here I believe I'm inside. So we remove the stylet and to flush.
No, you want to flush or to aspirate?
Oh, I will to flush a little bit. Scopy.
Fluo?
Scopy, fluoroscopy.
Can we have the fluoroscopy review?
Okay, we have a nice... You need the fluoroscopy now because it's a very nice picture.
So I want...
Yes, can we have the picture?
Water, please.
Thank you.
Wait.
Yes, we can.
Do you have the picture?
Yeah.
Okay.
So we are in the good biliary duct. So I flush with saline to insert guide wire. I can, as you want.
So of course...
I don't want to push too many contrasts inside because at this time it's not no indication to over-inject the intrahepatic duct to avoid to have many contrasts everywhere in the left lobe.
And we are using a J-wire that we can manipulate. Fantastic. Go back.
Yes. Okay.
Okay, here you are. Fantastic.
Probably.
That's very nice to be lucky sometimes, huh?
Sometime, yes.
But
So I remove, because it's a 19 gauge needle, we have risk of to strip the guide wire. So it's not useful to try to manipulate many times actually the guide wire. It's an indication to remove the 19 gauge needle. Scopy.
And this is the time when we must use fluoroscopy, huh? That's for sure. I don't know why the guide wire is not going deeper, but we will see that later on when we will be inside with the cystosome.
Yes. Copy.
Do you want me to inject on the other side to see what we do, or not really?
We can, but the last time I inject, you have no pass. The contrast. I have no cholangiography of the common bile duct.
Okay.
So
we just hope, of course, it's a patient who has that extended hepatectomy. We just hope that we are not in another secondary branch, huh? Which might be the case also,
maybe,
because we didn't find any resistance when passing through. But at least we are at the level of the stricture.
But at this time, we are in the bile duct, so it's important to remove the needle and to pass the cystosome after to search the good way. Because if we search at this time with the needle in place, the risk of to strip the guide wire is very important. Stop. Thank you.
From this time, this EUS guided procedure becomes a fluoroscopically guided procedure, of course. Huh? We don't need a EUS anymore.
So up. So we will enter with pure current current inside. Hopla, the bile duct, and so we follow the guide wire and we try to opacify. Florence, tu peux décaler un petit peu la scopie sur Merci.
The nice thing with this 6 French cystotome is that you can inject leaving the wire in place, so you should be able to do that. It's not always fantastic, but it works. No. It's a secondary branch.
It is not.
It's a secondary branch.
Non, ça passe pas. Bon, si. Sinon, we can remove the guide wire and inject after if it doesn't work. We need to have some cholangiography to know where we are.
So you see that maybe we have been in a secondary branch at the beginning, so that means that Erwan might have to pull back significantly the cystotome. Let's see what happens.
Yes.
No, that's a secondary branch. Huh? But we were in the good axis at the time of the puncture.
So I pull back the catheter, and we will try one more time with guide wire to find probably air.
C'est dans la partie dense. Hein?
Sorry. It's not a good way. So we'll change. I pull back to go. Yes, but okay, this way maybe.
No, this is again a secondary way. But you are there.
No. So I will try from here. I could be back, but maybe here. If you have to. Yes. which is this part? Stay here, stay here, stay here, stay here, stay here, because I don't know where he is. Yes, can I inject here? Celui-là, je l'ai pas opacifié la dernière fois. Je vais passer par là. Voilà.
Non, faut retirer le guide. Hein.
Hop, hop, hop.
Attends, attention,
C'est dedans, on est dans le foie là.
dans une veine. Là.
Ouais.
T'es dans la veine.
Ouais. Oula. On a trop retiré. Attends, on va essayer de retrouver. Très joli.
We are now
we are
the
still in
last
the
case.
same place. We are still in the same place.
The last case, I just tell you a little bit what happened since you left us. So Erwan and Sonia trying to find a way to the common bile duct, but as you can imagine, it's not easy in this distorted anatomy. You see that the external drain was in the side branch of segment 4. Erwan is now in the main part of the common segment 2 and 3, but the anatomy is really distorted. And if we think that the communication might be a very small orifice which is in a place that you see where the tip of the cystotome is on the left side of your screen, it can be everywhere because the anatomy having been distorted, we have more tendency to go to the dilated side branch than to go to this small orifice. And I'm afraid that restoring the anatomy in a first step will be difficult. So here we have two options. One is to do an hepaticogastrostomy, what Erwan will probably do, but leaving a stent which would be a fully covered stent in order to be sure that we do not compromise the possibility to remove the stent after that, and to come back a little bit later on with a cholangioscope or a spyglass scope to try to localize the orifice by a transgastric route, or to start again, having the possibility to inject there, leaving a catheter, and start again an ERCP, knowing that we will have the opacification on both sides, and that it may help in finding this tiny communication. Encore un peu.
The difficulty here is you have no opacification of the common bile duct to have an idea where is the structure. So Sonia try blindly to find this the orifice, but at this time it's always the same result in this patient.
The common trick that we use when we do PTC, and which can be the same in this case also even by US guidance, is that we leave a drainage for a while, but you see that this drainage was not optimal because it was distal to a side branch. But if you leave a good drainage for a while, you can have a decrease in the diameter of the bile duct, which makes the manipulation of the wire a little bit easier also.
So we will try to let hepaticogastrostomy with a fully covered stent and to come back.
I think that if we use a cover stent which is not too long.
No, 6 centimeters is probably enough.
6 centimeters is more than enough.
But 4 centimeters is probably too short, no?
Go for it. Just wondering, in this setting where you're having difficulty changing the angle of the wire, would it be worth considering exchanging
you have 4, but 4.
And
no, 6, 8 will be very long.
8 is too long. 8 is wrong. 6 and do double pigtail stent also. Maybe 2. Ouais, short. Yeah.
Can you take a question? I know it's difficult. You're concentrating. Can you take a question?
No problem. So the idea to let fully covered stent Yeah.
The
So
idea is to establish a tract.
To establish a
And
tract.
if we come back after leaving this 10 French stent in place in 2 weeks, we can even remove the stent. We will have a very solid tract to the bile duct that we can use to do a cholangioscopy, a transgastric cholangioscopy.
And you have to let inside the metallic, fully metallic stent, double BTEC stent, because there are risk of migration of the stent, of course, because it is fully covered.
You are confident with the cystotome for the passage of the stent?
Yes.
After that? It's
Yes.
relatively easy. Huh?
Yeah, usually it's
So
very
this
easy
is
to
the
pass. There are no need to dilate more the track to pass a metallic stent. Usually there are no problem with to pass a metallic stent after the 6 French cystostome.
So the stent that Erwan has chosen is a 6 centimeter fully covered stent evolution from Cook.
Yeah.
If you use material from different companies, you have to consider that the 6 centimeter from Cook are not equal to the 6 centimeter from other companies and vice versa, because the foreshortening of the stent really depends on the stent and its design, especially when you have a structure. So don't consider, especially when you place multiple stents side by side, that a 6 centimeter from Cook or from Boston or from Taewong or from any company is similar in length when deployed to another 6 centimeter.
Okay, Scopy. Can I have Scopy? Thank you. So I will push the stent inside the bile duct. There are no very difficult to push the stent. So now, because it is fully covered stent, we have to have a good position of the stent to have enough part inside the biliary duct to avoid migration, but not too deep to avoid to occlude side branch, large side branch. So it's probably the difficult part in this case to choose where is the best place to
and to be sure that you still have 1 centimeter into the stomach.
Yeah, yeah.
But I think that this size is perfect.
Probably yes. So we begin to open the stent because I pull back during Sonia opens the stent. Of course, I pull back the catheter to be sure to stay in place and to avoid to push the stent deeper in the bile duct. Sorry, stop.
Okay, you see that the stent is starting to deploy. It is in a good position.
Yeah.
And
now
probably Mark will go back to the endoscopic view. Probably Mark, probably Erwan. They are working so similarly, both of them, that...
Not yet. So I'll go back now because the stent
is father and son. Huh?
Okay.
Okay, let's go back.
Not good.
Okay, you see that there we have the yellow mark, so that means that we are a little bit too deep.
Too deep, yes.
And then Erwan will just pull back the stent 1 or 2 centimeter. We need a little bit more than that.
Okay. So I pull slowly, Scopy, to be sure to stay in good place. Good. As you see on the fluoroscopic image, tu peux commencer.
Yes,
you can open. When you need to have endoscopic.
Wait.
You need to have endoscopic pictures. The position of the scope is less stable. Open, Sonia, vas-y.
Yes.
Open. I pull. And you see the scope very close to the...
Tire encore un peu, Erwan.
I pull.
C'est bien.
Hardly.
Ok, retire l'attachement, la prothèse.
Oui.
L'attachement. Ah, tu l'as déjà?
Okay, the stent is in place. So I will try to avoid to put trop tard. I lose the guide wire. by up. So I lose the guide wire due to the position up. So
Un boule.
I will replace the guide wire. So we have two possibilities, or to
So
change the scope and to use duodenoscope. But we can try, if it's not difficult, using EWE scope.
The important thing here is not to manipulate too much. So it's just to go very gently with the wire ready.
So
Excellent. Excellent.
So it's not a lateral view, but 4 oblique view, so we are not in good place. So the idea is to just to push a little bit the catheter
Excellent.
and to
Vas-y, vas-y. Parfait. You are
wait
inside.
for the guide wire. Okay.
And there, don't push too much the stand. That's perfect.
Okay. Slowly. Okay. So
Excellent. This is the side branch, but it's not
can
bad.
I make a loop more in the bile duct? Okay. Not. Oh, yes, it's better.
that's even
Yes,
better.
good. Oh, it's good. It's good. I go back.
You double check that you are not
I go back.
occluding the major side branch.
I go back. Okay. So now we will try to place a double pigtail stand to avoid migration of the stand, because it's a risk in this situation.
But we see very well the imprint of the gastric wall on the fluoroscopy, as well as the imprint of the liver, and the part which is a little bit in between, which is more dilated, expanded.
Hop, hop, hop. Je suis dehors. So to perform cholangioscopy, probably we have to wait
I think
enough time, but not more time to
not too
avoid.
much. I
Not too
think
much.
1
1 week.
1 or 2 weeks is a good timing.
Yeah. There is some question in the audience, or
Il n'y a pas de marqueur? You have no marker? Why?
Aussi, je préfère un marqueur quand
Ouais.
même. Si on peut.
No, we are just waiting for a marker
A black
to
marker.
see
Yes.
the basis of the proximal pigtail.
What size of pigtail you will?
Here is a 7 French,
The size of
7
the
centimeters, longer than the metallic stent, and the diameter is not very important. 7 or 8.5 French is enough. 10 French are no.
But I would not, I
no
would not
interest.
use an 8.5 in this particular case, because the size of the pigtail in the 8.5 is much larger and will not be adapted to the size of the common bile duct. So in this case, it's just to prevent migration. So let's make it as simple as possible, and this is why Erwan has chosen the 7 French.
Mark on the middle of stand or?
I'm sorry, if you ask a question, I didn't catch it.
No.
You put a
Scoopy.
mark on the middle of the stand with a pen.
Okay.
Yes, with an ink pen. There are some stands which are pre-marked, but Usually the nurse is doing the mark immediately before. There's a black marker. And it's important to wait a few seconds to allow it to dry a little bit before pushing it. Yeah.
The stent is efficient. So I push slowly.
As Mark mentioned, it's a nice picture, fluoroscopic picture of the bile duct, which is completely empty, including the side branch, which confirms that the size chosen by Erwan was the good one.
Okay. So we push the stent up. The black marker is here, so we can. I don't know if you've seen the black marker. It's already inside. Sorry, I pushed too quick to show you.
It's okay. We see a part of the black marker there.
Okay. So we can remove the guide wire, and I will push in the gastric cavity the stent.
Okay.
So the length of the stent is adapted of the size of the metallic stent. So for time is okay.
Beautiful, Erwan. Beautiful.
Congratulations.